Hello everybody. I am Dr.Shreya Poddar. I am your faculty for dermatology at Global Academy of Medical Education. We'll be revising dermatology today, and we'll be doing it in two parts. Today, we'll be taking up mostly the infections of it because you get a lot of questions from infections in Fmge, right? We'll be doing it in a question answer based manner, and we'll take up all the relevant MCQ points while looking at those questions. So let's get started with our first question. Identify the image that has been given to you. See, this is very important. You have to remember this is an image of scabies mite. So sorry. This is an image of scabies mite. How will you identify a scabies mite? This mite has got two pairs of legs anteriorly and two pairs of legs posteriorly, right? So scabies mite will have two pairs of legs anteriorly and two pairs posteriorly. How will you differentiate it from pediculosis? So lice is more of flattened dorsoventrally, you can see, and it will have three pairs of legs, 1, 2 and 3, and in the end it is going to have claws, right, to have a firm grip on the hair, to attach itself to pubic hair, body hair, scalp hair. It will have claws, right? So it will have three pairs of legs and it will have claws at the end. So this is how you differentiate the two, and very important to remember that pediculosis, the lice is going to have three pairs of legs and claws at the end. Let's quickly revise scabies, right? What is the causative organism? The causative organism is Sarcoptes scabi var hominis. It's a infestation, it's a parasitic infestation caused by Sarcoptes scabi var hominis. What is the average number of mites per patient? 10 to 12, right? What is the incubation period? So see, if it's the primary infection, if the patient is getting infected for the first time, it's going to be 2 to 4 weeks. And if it's a reinfection, if it's a secondary infection, possibly from an untreated family member, the immune response is going to come up in a short time of 1 to 3 days, because the patient has already been sensitized to the scabies mite, right? What are the clinical pointers that will help you make a diagnosis of scabies? So see, the patient is going to have lesions in the finger webs. Involvement of finger webs, presence of papules and vesicular lesions in the finger webs is very, very characteristic of scabies. So papules in finger webs, number one. Another is nocturnal pruritus. The itching is going to be worse at night. So the itching is not so much there in the daytime, it's worse at night, and there is presence of family history. Usually you will have a family member, one or more, that is affected with the scabies mite. So presence of papules in finger webs, nocturnal pruritus, and presence of family history strongly points towards a diagnosis of scabies. What is the pathognomic lesion in scabies? Very important to remember, it's a burrow. Okay, burrow is the pathognomic lesion in scabies. What is it? It's a linear, wavy, or a serpentine tract that is made by the scabies mite as she digs into the skin of the patient. So it's a linear or a wavy or a S-shaped tract made by female mite as she digs into the skin. What is the level of burrow? It's present in stratum corneum. Stratum corneum, okay. How many eggs does the mite lay per day? It's 3 eggs per day, right? So the mite is burrowing into the skin, so the advancing edge of the burrow is going to have the mite. So as the patient is going to itch it, it dislodges the mite, right? Now what is the classic distribution of scabies? So you have lesions in the finger webs, we looked at it. Then you have lesions on the wrist, okay. Then you have lesions in the anterior axillary fold. anterior axillary fold. Then you have it in the mammary area. Then you have it in the peri-umbilical area or the umbilical area. And lastly, you have it in the genitalia or the groin. Okay. So these are the classic sites where you will get lesions of scabies. See, it's very important to remember the morphology. It's very important to remember the distribution and whether it is symptomatic or asymptomatic or associated with symptoms like itching, pain, burning. In any cases of in any case of dermatology. So in scabies, you get papular lesions. Sometimes you can get vesicles, and sometimes you can get lesions that are pustules because of secondary bacterial infection. So you get papular lesions in the web spaces. You get it in wrist. You get it in the flexor of elbows also. You get it in the flexor of elbows. You get it in the axillary folds, the mammary area, the peri-umbilical area, and the groin. Now all this, if you connect together, forms an imaginary circle. What is this called? It is called as the circle of Hebra. So circle of Hebra is related to scabies, right? Coming to another question, which of the following is most severe form of scabies? Now see, you have looked at classic scabies. You have looked at the classic clinical pointers. Now there are three variants that you have to remember: nodular scabies, crusted scabies, and infantile scabies. See, infantile scabies will involve the face also. Okay, in adults, in classical scabies, the face, the palms, and the soles are spared. But in infantile scabies, you will have lesions on face, palms, and soles. Okay. Now, what are nodular and crusted scabies? See, this is an example of crusted scabies. You're getting very hyperkeratotic crusted lesions. Hyperkeratotic crusted lesions. And you can also get dystrophic nails. Dystrophy of nails, right? So, this is called as hyperkeratotic scabies. Crusted scabies or Norwegian scabies. Why Norwegian scabies? Because it was first identified in leprosy patients of Norway. So it's also called as Norwegian scabies. Now everybody does not have such severe form of scabies. Which is the susceptible population? See, HIV patients or immunocompromised patients. Patients of Hansen's disease, or patients who are, mentally retarded or have conditions like Down syndrome. These are patients who are affected by Norwegian scabies. Now what happens is you get hyperkeratotic crusted lesions and you get millions of mites in these patients, millions of mites. Okay, and there is absence of itching. Why? Because patients of HIV, they will not have an immune response to the mite. They are immunocompromised, they are immunosuppressed, right? So the patient is not going to itch because there is a lack of immune response, and hence the mite is not going to dislodge when the patient is itching it. So the patient is going to have millions of mites. Hansen's disease, there is sensory impairment. Again, the patient is not going to itch it, and he will land up having hyperkeratotic scabies. Again, patients of mental retardation, there is impaired perception of itch, right? So impaired transmission or impaired perception, all of this is going to lead to absence of itching, and eventually the patient is going to have millions of mites, and the patients will have hyperkeratotic crusted lesions and nail dystrophy. So this is the most severe variant of scabies. Another scabies variant that you have to remember is nodular scabies. This is a hypersensitivity response. to the scabies mite. Okay, what do you get? You get nodular lesions in the axilla or the genitalia, right? You get nodular lesions in axilla or genitalia. So this is another variant of scabies. See, you are getting nodules here, right? You're getting nodular lesions. Which of the following scabicide agent is not pregnancy safe? See, remember, oral ivermectin cannot be given in, it's contraindicated in pregnancy, lactation, and patients having weight less than 15 kg. Okay, so you cannot give it to pregnant and lactating females. So scabicide that you will not give in pregnancy is oral ivermectin. Permethrin 5% cream is the drug of choice in scabies. How does it act? It acts on sodium channels. This leads to paralysis of mite. Okay, another important question. And what is the dose? So in adult, 30 gram of cream has to be applied, kept overnight. In a child, 15 grams, and we give it for a short contact time. What is the general contact time that we give in an adult? It's 12 hours. Okay, it is kept overnight, it's applied at night, and it is washed off in the morning. Precipitated sulfur is actually the safest in pregnancy, but it's not given because it has a very messy application, it has an odor, so we prefer giving permethrin 5% cream only. Lindane, if one point you had to remember, you will remember CNS toxicity. Lindane is neurotoxic. So if the patient has a pre-existing CNS condition, you will not give Lindane to that patient if he or she lands up with scabies. And oral ivermectin, few points that you'll remember is it acts on GABA gated chloride channels. Okay, it acts on GABA gated chloride channels. What is the dose? 200 microgram per kg, 2 weeks apart. Okay, this is what the standard dosing is, 200 microgram per kg, 2 weeks apart. And of course, I told you it's contraindicated in pregnancy, lactation, excuse me, and in patients who are weighing less than 15 kg. So this is a review slide of scabies having all pertinent points, which you can get as MCQs for scabies. So please take a screenshot and you can revise it later on, right? Let's go to pediculosis. Now pediculosis, just briefly, you can have pediculosis capitis, you can have pediculosis corporis, this is body lice, this is head lice. Okay, and you can have pediculosis pubis, which is an STD. Okay, now pediculosis capitis, how is it going to present to you? You will get papular lesions on the scalp, you will have complaint of itching, and if you examine, you will have eggs and nits and lice on the hair shaft. And you will get posterior cervical lymphadenopathy, very commonly seen in patients of head lice. Sometimes they will come and tell you that they have this swelling in the cervical area and itching on the scalp, right? So please remember, it is a very classic feature of pediculosis capitis. It's often found in these patients. Now pediculosis corporis is also body lice and called as vagabond's disease. vagabond's disease, okay, because it is a disease of poor homeless because of self neglect. Now this lice will reside in the seams of clothing. It will come out at night from the clothes onto the skin of the patient. It will feed and it will go back. So during treatment, laundering of the clothes is a must because it often resides in the seams of clothing, right? And last is pediculosis pubis. One important MCQ point you have to remember here is macula ceruli, right? Macula ceruli. What are these? These are brown colored macules that you get on trunk and inner thighs because of altered pigment, okay. So macula ceruli is related to pediculosis pubis. Vagabond's disease, pediculosis corporis, the lice will reside in seams of clothing, which is why you have to wash off all your clothes, all the clothes of the patient. And pediculosis capitis, you will get nets and lice on the hair shaft. They will be very, strongly adherent on the hair shaft. Whereas scales of seborrheic dermatitis, sometimes it is confused with seborrheic dermatitis, but the scales of seborrheic dermatitis can be easily flicked off. They will not be attached to the hair shaft, but nets and lice will be firmly attached to the hair shaft, and you will also get posterior cervical lymphadenopathy, right? Let's move on to the next question. You have to name the causative organism. So see, first you have to identify the condition. So let's describe the lesion. What you're getting here is a pearly white papule, right? Pearly papule which has umbilication, right? Umbilicated and present on the face. So you have pearly white papular umbilicated lesions on the face, very classic of a viral infection, molluscum contagiosum, right? Molluscum contagiosum. So molluscum contagiosum is a viral infection. It's caused by molluscum contagiosum virus. There are 4 types: MCV 1, 2, 3 and 4, and it is a pox virus. So the answer is going to be pox virus, right? Out of this, the most common is MCV 1. Okay. Now, which is the most common site you get lesions on? Face, okay. Which is the most common population that it affects? It affects a child. So, if you get a clinical question, it's going to be a child mostly with asymptomatic pearly white papular umbilicated lesions. In the same context, let's discuss where do we get umbilicated lesions. So one is molluscum contagiosum. Other important conditions that you have to remember is cryptococcosis, histoplasmosis and penicillosis, okay. Molluscum contagiosum, you will get umbilicated lesions, cryptococcosis, histoplasmosis and penicillosis. These are 4 conditions that you remember that have umbilicated lesions. So coming back to molluscum contagiosum, it's caused by a pox virus, molluscum contagiosum virus, most common of which is MCV1. The most common site is face and the most common population is child. Another important thing, what are the diseases caused by pox virus? So one is molluscum contagiosum, then you have ORF, right? ORF is caused by a parapox virus. Then you have variola, which is smallpox. And then you have pseudo cowpox, okay. So these are all conditions that are caused by pox virus. So you may get a question that all of these diseases are caused by pox virus except, and you have to remember all of those conditions. Okay, then comes the next question, which is inclusion body seen on histopathology of molluscum contagiosum. See, when this virus infects the keratinocytes, there is formation of a inclusion body. It is an intracytoplasmic inclusion body, and it's called as Henderson-Patterson body. So remember, Henderson-Patterson body. Molluscum body or Henderson-Patterson body, it's an intracytoplasmic inclusion body, right? These are all infected keratinocytes, and you have intracytoplasmic inclusion bodies called as Henderson-Patterson bodies. Now let's look at the other options. Where do you get CVAD bodies? You get it in lichen planus. Okay, what are these? These are apoptotic keratinocytes that have gone from stratum basale to the dermis. So these are apoptotic actually keratinocytes. So it's called as CVAD bodies. Asteroid bodies you get in sporotrichosis. Okay, and Donovan bodies you get in donovenosis. What is the causative organism of donovenosis? Calymatobacterium granulomatis, right? And lichen planus is an immune mediated inflammatory dermatosis. You get remember the 5 P's: purple, plain, pruritic, papular lesions on the classically present on the wrist and the extremities. So lichen planus you get CVAD bodies. Molluscum contagiosum you get Henderson-Patterson bodies. Sporotrichosis you get asteroid bodies, it's a deep fungal infection. And Donovan bodies you get in donovenosis, right? So another question that we are going to look at is: a child presented to you with string of pearly white umbilicated papules. What does the figure depict? So you're getting pearly white umbilicated papular lesions in the child. You're looking at a case of molluscum contagiosum, right? And the lesions are present in a linear fashion. Now this is pseudo-Koebner phenomenon. If you have read it previously, you know what pseudo-Koebner phenomenon is. It is because of auto-inoculation of the organism. It is because of auto-inoculation of MC virus. Okay. Now what is Koebner and what is pseudo-Koebner phenomenon? First let's look at that. Koebner phenomenon is occurrence of lesions of similar morphology following trauma on a previously unaffected site. So say if you had a patient of psoriasis and you have a clear skin which is not involved with psoriasis, but there is trauma to that skin. So this will result in development of new lesions of psoriasis on the trauma inflicted skin. So this is called as Koebner phenomenon. You get lesions of similar morphology. You will get similar lesions of psoriasis on the area where the patient had trauma. So it is precipitated by trauma. Trauma is the inciting factor which leads to Koebner phenomenon. So it is occurrence of lesions of similar morphology following trauma to an uninvolved skin. Okay. Now because there is occurrence of lesions of same morphology, it is also called as isomorphic response, right? Isomorphic response. It's called as isomorphic response. Now where do you get true Koebner phenomenon? What we looked at was pseudo-Koebner phenomenon. True Koebner phenomenon is because of trauma. So you get in true Koebner phenomenon, you get in 3 conditions: psoriasis, vitiligo and lichen planus. Okay, remember these three conditions you have: true Koebner phenomenon, pseudo Koebner phenomenon you have in molluscum contagiosum and warts. Both of them are viral infections, and it is because of inoculation of the organism because of trauma. It gets transferred from that site to a nearby site. So that is why you get new lesions. It's not because of trauma that is leading to new lesions of MC or warts. So you called it pseudo Koebner phenomenon. What are the rare cases where you get pseudo Koebner phenomenon? You get it in erythema multiforme. This has been asked also previously. Erythema multiforme. You can also get it in lichen sclerosus atrophicus, right? So these are some rare examples of rare cases where you get where you get isomorphic response or Koebner's phenomenon, right? Let's look at other options. What is Besnier's sign? Besnier's sign is something that you see in pityriasis versicolor. What is pityriasis versicolor? It's a superficial fungal infection of the skin wherein you get hypopigmented lesions, perifollicular lesions which are coalescing together, and they have very fine scaling. And sometimes the scaling is not even evident. So when you scratch those lesions with the help of your thumbnail, you get very fine powdery briny scaling, and that is called as Besnier's sign. So Besnier's sign is seen in pityriasis versicolor. Groove sign you get in LGV, lymphogranuloma venerum, right? We will look at the picture right now. And Auspitz sign you get in psoriasis. All of them are very important. One-liners you can get in your Fmge examination. So see, this is a patient who has vitiligo, right? You can see depigmented patches, and you can see a linear lesion here, possibly because of trauma. And this is a vitiligo patient with Koebner response, okay? What is happening here? You're getting string of linear lesions, right? This is plain wart, verruca plana, plain wart, and you're getting a pseudo Koebner phenomenon here. You're getting a pseudo Koebner phenomenon here because of auto inoculation of the HPV virus. Right? So this is plain warts, and you're getting pseudo Koebner phenomenon here. Now see, what is this? What you're getting is the erythematous plaque, right? Erythematous plaque with scaling. And what sign I'm trying to explain here is the Auspitz sign. Now what is Auspitz sign? This is a psoriatic plaque. This is a plaque of psoriasis, and probably it was heaped with scales here also. Now what happens is, when you get a classic lesion of psoriasis which is heaped up with scales, you take a glass slide and you try to remove the scales until there comes a very shiny red membrane. What is the name of that membrane? It's called Berkeley's membrane. You remove the scales and you get a very shiny red glistening membrane, and that is called the Berkeley's membrane. And once you remove that, you get pinpoint bleeding, right? See all those pinpoint bleeding dots. Now this is called as Auspitz sign, and it is classic of psoriasis. Why do you get Auspitz sign? Why are you seeing pinpoint bleeding? See, in psoriasis the blood vessels have dilated, right? And they have moved towards the epidermis. They have moved upwards, they have migrated, and they are tortuous and dilated. So now this is how they are present. They are present vertically, right? And you are removing the scales like this. So if you see on cross section, you will see pinpoint bleeding spots. So this is Auspitz sign, very important to remember, and you get it in psoriasis, right? Coming to this, what are you seeing? You're seeing a erythematous patch which has a scale, right? It has a collar like scale. So this is a collarate scale. What is this? It is seen in pityriasis rosea. It is seen in pityriasis rosea. So pityriasis rosea will have a collar-like scale, and when you stretch these scales along the long axis, when you stretch the lesion along the long axis, these scales tend to fold inward like a hanging curtain. So it's called as the hanging curtain sign. Very important again, hanging curtain sign, right? So hanging curtain sign seen in pityriasis rosea, and the lesions will have a collar of scale which is called as a collarate scale. And here what do you get? You get silvery scales or micaceous scales. Silvery scales or micaceous, mica-like scales, okay? Now let's look at this first. What do you see? This is the groove sign. See, the inguinal ligament being separated by the inguinal and the femoral group of lymph nodes. So this is the groove sign that we see in LGV, lymphogranuloma venerum, caused by Chlamydia trachomatis. Very important again. You can get any of these in questions. What is the causative organism? Chlamydia trachomatis. What is the sign that we are looking at? Groove sign. And what is groove sign? It's the inguinal ligament that is separated by the swollen inguinal and the femoral group of lymph nodes, right? What is this? See, this is actually what I'm trying to show you is the Dory-Flop sign. Dory-Flop sign in syphilis, primary syphilis. What happens is you get a painless indurated ulcer or a papule on the glans, and when you try to retract the prepuce, it flaps back in a characteristic fashion. So just remember, Dory-Flop sign, if you get, it is seen in syphilitic chancre. Okay. So this is again a review slide for you to take a screenshot and revise it whenever you are free. Besnier's sign or scratch sign, I've already explained. Pityriasis versicolor. When you scratch the lesions from with the help of your nail, you get very fine scaling, and that is something that helps you make a diagnosis of pityriasis versicolor, because sometimes the scaling is not very evident. Auspit sign seen in psoriasis, pinpoint bleeding when you remove the scales. And what is the test known as? This test is known as grattage test. Okay, remember, this is the grattage test. So if you do a grattage test, you ultimately remove the scales, you reach a membrane which is red, moist, glistening, and it's called the Berkeley's membrane. When you remove that membrane, you get pinpoint bleeding spots, which is the Auspit sign, right? Now hanging curtain sign we have looked at, we get it in pityriasis rosea. Groove sign, lymphogranuloma venerum. Koebner's phenomenon, true Koebner's you get in psoriasis, lichen planus, vitiligo. Pseudo Koebner you get in warts and molluscum contagiosum. Dory-Flop sign you get in syphilis, right? And another very important sign is Nikolsky sign. What is Nikolsky sign? Nikolsky sign is suggestive of acantholysis, right? What is acantholysis? Acantholysis is breakdown of desmosome. Breakdown of intercellular connections between the keratinocytes, which are desmosome, right? What are the disorders where you get a breakdown of desmosome? You get it in pemphigus, pemphigus vulgaris, foliaceous, desmoglin 1, desmoglin 3, it's broken, right, because of autoantibodies. You also get it in staphylococcal scalded skin syndrome. There is a breakdown of desmoglin 1, right? So you will get a Nikolsky sign here also. In 10 you get a pseudo Nikolsky. Why? You get a pseudo Nikolsky. Why? Because here there is no acantholysis, here there is necrolysis, here there is keratinocyte necrosis. So what happens is, when you apply tangential pressure, like you do in while you are eliciting Nikolsky sign, you apply tangential pressure and the epidermis will shear off from the dermis, because there is necrosis of keratinocytes there and not acantholysis. So it is actually pseudo Nikolsky, but it looks like, there is no acantholysis. There is actually keratinocyte necrosis, which is why the epidermis is easily sheared off. So in 10 you get pseudo-Nikolsky, but pemphigus and staphylococcal scalded skin syndrome you will get Nikolsky sign because there is acantholysis. Okay, coming to next question, hand, foot, mouth disease is caused by. See, it's a very important question, very frequently asked. Hand, foot, mouth disease is caused by Coxsackie A16. It's a viral infection, very commonly seen in children. Recently, we had an outbreak of hand, foot, mouth disease. The entire class was getting affected because it is so contagious, and we had strings and lines of patients having hand, foot, mouth disease, right? What do you get? You get papillary lesions and vesicular lesions. Papillovesicular lesions which have a red halo. Okay, so the morphology of the lesion will be papules and vesicles which have a erythematous halo. And where do you get it? You get it in the palms and soles. You get it in the oral, perioral area, oral mucosa. You get ulcerations, and you get it in the buttocks. So a child who is presenting with papules and vesicles with an erythematous halo in the palms and soles, in the buttocks area, you are looking at a case of hand, foot, mouth disease. What is the causative organism? Causative organism is Coxsackie A16. Treatment, nothing you have to do. It's a self-limiting condition. Just advise isolation, and if it's of course itchy, you can give some topical soothing lotion, calamine, and some antihistamine, right? Rash of varicella is another very frequently asked question. Rash of varicella is, please remember, it's centripetal and pleomorphic. Why pleomorphic? Because at one particular point of time you will get lesions of varied morphology. You will get papules, you will get vesicles, you will get crusted lesions. So you will get papules, vesicles, crusted lesions, right? It is caused by human herpes virus 3, varicella zoster virus. You have to advise isolation to the patient, right? And you get a rash which is centripetal and pleomorphic. What is the best treatment for this condition? First, we have to identify what we are looking at. So what are we looking at? Let's describe this. We are looking at a case where you are getting grouped lesions, right? You have got multiple lesions present in groups. See? So you have grouped lesions, vesicular possibly, not so clear in the picture though, but these are vesicular lesions, and they are present on a red base, erythematous base, right? And they are present along a dermatome. See, it's involving a dermatome. So it's a dermatomal rash having grouped vesicular lesions on a erythematous rash. So what is this? This is herpes zoster. Herpes zoster. Grouped vesicular lesions on an erythematous base in a dermatomal distribution, and painful. Remember, it's very, very painful. If you get a clinical question, it's a very painful rash, right? What is the treatment? You will give an antiviral. You can give acyclovir or you can give valacyclovir. So the answer is valacyclovir here. Let's look at other options. Where do you give benzathine penicillin? Benzathine penicillin is the drug of choice in syphilis. Okay. What is itraconazole? Itraconazole is an oral antifungal. So you give it in fungal infections. You can give it in dermatophytes. You can give it in pityriasis versicolor. You can give it in subcutaneous mycosis, right? So it's an antifungal. Ivermectin we have already discussed. Ivermectin you will give in scabies, severe scabies, like crusted scabies. You can give it in cutaneous larva migrans. There also we give ivermectin. Okay. So we are looking at herpes zoster. What is a very common complication of herpes zoster? Post-herpetic neuralgia. Post-herpetic neuralgia. Right? It's a very common complication because the pain, burning sensation persists even after the rash has resolved. So it's a condition that has to be treated with neuroleptics. You have to give tricyclic antidepressants, gabapentin, pregabalin. So that is the treatment for post-herpetic neuralgia. See, two complicated herpes zoster conditions you have to remember. One is herpes zoster ophthalmicus. So what you're looking at here is herpes zoster ophthalmicus. Now this involves the ophthalmic division of the trigeminal nerve. Ophthalmic division of the trigeminal nerve. And what is one sign that is associated with herpes zoster ophthalmicus? It is Hutchinson sign. Hutchinson sign. What is Hutchinson sign? See, if you get vesicles on the tip of the nose, there is an increased chance of corneal involvement. So herpes zoster ophthalmicus is involving the ophthalmic division of the trigeminal nerve. You get lesions in a dermatomal pattern and you get grouped papillovesicular erythematous crusted vesicular lesions on a red base, and you can have eye involvement also. And if you get vesicles on the tip of the nose, then chances of eye involvement are going to be very high. So this is Hutchinson sign. Another condition that you have to remember is herpes zoster oticus. Now this is herpes zoster oticus, right, which is also known as Ramsay-Hunt syndrome. So this involves the ipsilateral 7th nerve, and you get vesicles on the external ear canal. So you get vesicles in the external ear canal, and it's a very painful condition. So you will get otalgia, earache, and it involves the geniculate ganglion, right? It involves the geniculate ganglion. You have ipsilateral 7 nerve palsy, okay, also known as Ramsay-Hunt syndrome. So two complicated zoster conditions that are very painful, require intensive management is herpes zoster ophthalmicus. You have to refer to an ophthalmologist also because there is eye involvement, and herpes zoster oticus. There is severe earache, there is involvement of the geniculate ganglion, there is swelling of the facial nerve, and there is presence of vesicles on the external ear canal, right? How will you treat it? You will give acyclovir or valacyclovir, right? Now identify the given image. What you are getting here, we have already discussed it. See, there is a erythematous patch which has a collar-like scale, right? It is very characteristic of pityriasis rosea. So the answer is B. Now let's look at few MCQ points of pityriasis rosea. What is the first lesion that develops in pityriasis rosea? It's a herald patch. Herald patch, okay. This is the first lesion to develop in patients of pityriasis rosea because it heralds the development of other lesions by 2 to 3 days, and it's seen here in the trunk. See, it can be present on the neck, trunk. So this is the first lesion to appear. Scaling, we have already learned, we get a collarate scale, okay. Sign, we've already discussed, hanging curtain sign. Hanging curtain sign, because when you stretch the lesions along the long axis, when you stretch these lesions along the long axis, these scales tend to fold inward. So this is known as the hanging curtain sign in pityriasis rosea. What is the distribution? See, the lesions are distributed in the back in a fir tree manner, fir tree appearance, right? So it has an inverted fir tree appearance. Inverted fir tree appearance, okay. The lesions will spare the Palms and soles. Palms and soles are spared. So all of these are potential MCQs. Which of the following body site is not involved in pityriasis rosea? So the correct option will be palms and soles. You do not get lesions on palms and soles. The lesions are distributed on the back in an inverted fir tree appearance. The sign is hanging curtain sign. Collarate scale you get in PR, and the first lesion is herald patch. And what is the causative organism that has been said to be associated? It is human herpes virus 7, HHV7. Another very important MCQ. HHV7 has been shown to have an association with pityriasis rosea. This condition again is self-limiting. Remember, it's a self-limiting condition. Okay. Correct. Now, moving to the other question. Which of the following virus is from herpes family? See, you have to remember the human herpes virus. All the viruses. Human herpes viruses 1 to 8. You have to remember. So let's look at them first and then we'll solve the question. So see, human herpes viruses, there are 8 groups that you have to remember. HHV1 is actually HSV1, human herpes simplex virus, and that is causing orolabial herpes, right? HSV2 will cause herpes genitalis. Again, a very important slide. Please take a screenshot so that you can revise. HHV3 will cause varicella zoster. Now, this zoster virus only remains dormant in the sensory root ganglion of the spinal cord, and at times when the immunity is depressed, it reactivates and it travels along the spinal nerve and causes lesions in a dermatomal fashion, right? It leads to herpes zoster, which is why you get lesions in a dermatomal fashion. What is a dermatome? It's the area of skin that is innervated by a single spinal nerve, right? So when the virus travels along that nerve, it leads to lesions in that dermatome. HHV4 is actually Epstein-Barr virus. It causes infectious mononucleosis and it also causes oral hairy leukoplakia. Right? Very important question. Oral hairy leukoplakia is caused by Epstein-Barr virus. HHV5 is cytomegalovirus. It causes a IM-like illness, infectious mononucleosis-like illness. HHV6 causes exanthum subitum or roseola infantum. We will come to this. There is a question on this. HHV7 will cause pityriasis rosea. It has been found to have an association with PR. And HHV8, it causes Kaposi sarcoma, right? So this is again a very important slide. You have to remember all the human herpes viruses. So again, the answer is going to be D. Epstein-Barr virus is from the herpes family, right? Okay, so now we move on to our next question. Condyloma acuminata is caused by. You can see in the question you are getting very fleshy verrucous lesions, right, which have pointed ends and flat bases, broad bases. So pointed lesions on the genitalia, verrucous pointed lesions, it is a genital wart, also called as condyloma acuminata. Okay. And what is the causative organism? The causative organism is human papilloma virus. Now there are low risk HPV types and high risk HPV types that you have to remember. So HPV 6 and 11 is actually a low risk HPV virus, and HPV 16 and 18 are high risk. Chances of transformation are more. So condyloma acuminata is actually genital wart. Acuminata means pointed. So you get pointed fleshy verrucous lesions in the genitalia, and it's caused by human papilloma virus, right? How will you treat it? You can apply podophyllin. Imiquimod, right? And if the patient is pregnant, so if you get genital wart in a pregnant female, it is also an important question. In pregnancy, either you will do a cryotherapy or you will apply TCA. Okay, so TCA application and cryotherapy. And if it's a very giant condyloma, you will do a surgical excision, right? So you can also do a surgical excision. So remember genital warts, remember the HPV types, remember the morphology. It's very important. This is again a HPV review slide. HPV, human papilloma virus, is a DNA virus, right? So there are certain HPV types that you have to remember that are associated with the warts that they cause. HPV causes warts, right? Sorry. It's a DNA virus. So see, type 1 and type 2 are going to cause plantar warts on the plantar surface. This will cause a deep plantar wart, HPV 1. This will cause a superficial plantar wart. Okay. 3 and 10 will cause plain warts. Remember when we saw pseudocoebular phenomenon, we were getting flat lesions, flat skin colored or little bit hyperpigmented lesions, asymptomatic, numerous lesions, pseudocoebular phenomenon also present, plain warts. Type 3 and type 10. Type 4, 2 and 27, just for the sake of remembrance so that you remember it easily. It's caused by, I've written it in this fashion, like 1, 2, 3, 4, 5, 6 and 7, and then the additional HPV types I've added. So 4, 2 and 27 will cause verruca vulgaris, which is common wart. So it causes verruca vulgaris. They are more verrucous, than plain warts. Plain warts are flat topped, whereas verruca vulgaris will be verrucous. Then type 5 and 8 causes a condition called as epidermodysplasia verruciformis. Now this condition has a genetic predisposition and you get plain wart-like lesions on the extremities and you get hypopigmented lesions on the trunk. Nevertheless, remember what are the types that are associated? Type 5 and 8. Now type 6 and 11 we have looked at, causes genital wart, right? And type 7 causes butcher's wart, okay? So this is again very important, HPV types that cause certain warts. Remember this. Next question, 6th day disease is. Please remember there are some named diseases, right? So you have to remember all the named diseases. So 6th day disease is exanthem subitum, right? What is erythema infectiosum? Let's look at them. This is caused by parvovirus B19. It's a viral infection caused by parvovirus B19. You get a slabbed cheek appearance. You get a slabbed cheek appearance here, right? And you get lacy reticulate lesions on trunk and extremities, right? So slabbed cheek appearance and lacy reticulate lesions on trunk and extremities you get in erythema infectiosum, and it's caused by parvovirus B19 and it is also called as 5th disease, right? Now exanthem subitum is called as 6th disease. It is also known as roseola infantum, right? You get rose colored macules. So what happens, it involves the infants, hence the name roseola infantum, okay? And most often in children less than 2 years, 90% of the cases they happen in children less than 2 years of age, and most common is the infant age group. and you get rose colored lesions, hence the name roseola infantum. So the patient will have fever, right? And as soon as the fever subsides on third or fourth day, then the patient is expected to improve. But then there is a surprise appearance of the rash, which is why it is called exanthum subitum. Exanthum is a rash and subitum is surprise appearance. So fever plus rash, and the rash makes a surprise appearance as soon as fever subsides. Right? So it is called as exanthum subitum, a surprise rash occurring after defervescence. And it's called as sixth day disease. Again, it's a self-limiting condition. You do not need to treat it very actively. Erythema marginatum is associated with rheumatic fever, and erythema nodosum is actually a paniculitis. Okay, it's an inflammation of the fat. So please remember erythema infectiosum, it's fifth disease caused by parvovirus B19, and sixth disease is caused by HHV6, right? And you have a surprise appearance of the rash as soon as the fever subsides, and it's a self-limiting condition mostly affecting infants, and you get rose colored macular rash. Again, take a screenshot. I've prepared this for you all so that you can just revise that on the go whenever you are free. So first disease is measles, caused by measles virus. What are key points that you can remember? You get Koplik spots in the mucosa, right? So Koplik spots is a feature of first disease caused by measles virus, right? Second disease, scarlet fever. Scarlet fever is caused by streptococcus pyogenes. You get Pastia's lines and you get a strawberry tongue. Pastia lines are exaggerated lines, hyperpigmented lines that you get in the creases. You get it in the cubital fossa, right? So these are Pastia's lines. Another important line I would like to mention quickly is Blaschko's lines. Examiner's favorite, Blaschko's lines. These are lines of embryonic development, okay, of skin. Right? These are lines of embryonic development of skin, Blaschko's lines. How will you identify them? They are present on the entire body. They are linear on the extremities, and on the abdomen they are S shaped or spiral. So they are S shaped on the abdomen. I'll put a picture next time, okay? S shaped on abdomen. So this is how you identify the Blaschko's lines. Another lines, last one I promise, is Langer's lines, okay? Remember Langer's lines. Langer lines are also known as relaxed skin tension lines, okay? Relaxed skin tension lines. What are these lines? These lines correspond to orientation of collagen fibers in the dermis. So they correspond to collagen fibers, okay? Orientation. So they are very helpful in guiding surgical incisions, because if you make an incision around the along this line, it leads to better wound healing. So Langer's line and Blaschko's lines, right? Two lines that you have to remember. Another line is Pastia's lines. Pastia's lines you get in scarlet fever, and another thing you remember is dermatome. Dermatome is an area of skin which is innervated by a single spinal nerve, right? Third disease, German measles caused by rubella virus, and you will remember Forsheimer spots here. You get Forsheimer spots here, okay? Fourth disease, staphylococcal scalded skin syndrome. Now this was previously known as Ritter's disease or Ford disease, and it's caused by Staphylococcus aureus. We will come to a question on this later, and you get a positive Nikolsky sign here because desmoglein 1 is being cleaved, right? So you get a positive Nikolsky here. Fifth disease we have already discussed. It's called erythema infectiosum. It's caused by parvovirus B19. You have a slabbed cheek appearance. You get a erythematous rash on the cheeks, both the cheeks, as if someone has slapped the child, and you have a lacy reticulate rash. And sixth disease is roseola infantum or exanthum subitum. I've explained you why. It is caused by HHV6, and you get lesions, you get Nagayama spots. Okay, so these are very important key MCQ points, one liner points that you have to remember about these named diseases. Okay, now moving on to fungal infections. Few questions on fungal infections. A man presented with asymptomatic hypopigmented lesion on trunk since 1 month. On examination, you notice fine scaling. See, I've already discussed this. Fine powdery like scaling, hypopigmented lesions, very classically involving the trunk and the proximal extremities. What is this? This is pityriasis versicolor, right? Classic site is trunk and proximal extremity. Okay, and this condition is pityriasis versicolor or tinea versicolor. Okay, right? So you have hypopigmented fine scaly lesions, and these lesions are coalescing together. See, the lesions are coalescing together and they're perifollicular. So this is pityriasis versicolor. What is the etiology? What is the causative organism? Malassezia globosa. Okay, so the causative organism is Malassezia globosa. We have discussed HHV7. HHV7 is related to pityriasis rosea, not pityriasis versicolor. Parvovirus B19 is going to cause erythema infectiosum. Treponema pallidum is the causative organism for syphilis, right? We will look at STDs. We have a review slide on STDs also, right? Why is this hypopigmented lesions happening in tinea versicolor? It is because of production of azelaic acid, right? So the answer is azelaic acid. It is because of production of a dicarboxylic acid called as azelaic acid by the fungus, which is leading to hypopigmented lesions. You know, sometimes you can also get hyperpigmented lesions. We call that pigmented pityriasis versicolor. Now that is an inflammatory response to the yeast, an inflammation to the yeast in the body leading to hyperpigmentation. But classically, if you see, you get hypopigmented lesions. Okay. Which of the following is found in tinea versicolor? Again, a previous year question. You get a spaghetti and a meatball appearance. I've given you the image to make it more easy. It's spaghetti and meatball appearance, right? Why do you get it? See, Malassezia globosa is a dimorphic fungus, which means it can exist in yeast and mycelial forms both, right? So you have the mycelia, you have the yeast, and because of this dimorphic nature of the fungus, you get an appearance which is spaghetti and meatball appearance. Where do you get grains? Grains is characteristic of mycetoma. You have a question on mycetoma also. These are colonies of organisms that are discharged from the sinuses. So you have grains and mycetoma. Skybala is found in scabies. Okay. If you do a scraping from a skin lesion, from the web space or any skin lesion, and you do a KOH mount, you can see the scabies mite. Sometimes you can see fecal pellets, which is called as skybila. Okay. And clue cells, very important again. Clue cells, where do we get it? We get it in bacterial vaginosis. Okay, bacterial vaginosis. It's going to be discussed. We'll come to a question on vaginal discharge. So bacterial vaginosis, we get clue cells, right? So this is a review slide on tinea versicolor. Because of shortage of time, I've prepared this for you all. Tinea versicolor, why versicolor? Because you get a variety of colors. I told you classically you get hypopigmented, but you can get hyperpigmentation as well because of an inflammatory response to the yeast. Sites we have discussed. The causative organism is Malassezia globosa, and there are others called as Furfur sympodialis, but mainly you remember Malassezia globosa. Then it's a dimorphic fungus, which is why you get a spaghetti and meatball appearance. Predisposing factors would be hot and humid climate, right? Tropical, hot and humid, warm climate. And hypopigmentation is because of azelaic acid. Hyperpigmentation is an inflammatory response to the yeast. Wood's lamp, very important. Wood's lamp finding of Pityriasis versicolor, you get a yellow fluorescence. Sign we have discussed, the Besnier's sign or the scratch sign. These are things we have already discussed. I've just put it here for you in one slide. How do you treat? You give azoles, you can give selenium sulfide. Orally, you can give fluconazole or itraconazole. What you don't give is griseofulvin. So, this was also asked, I think, one year. Griseofulvin, you will not give in. It is of no use in tinea versicolor, it will not act. So, what you give is azoles, right? Let's revise Wood's lamp, very important question. So, Wood's lamp is a very handy investigative tool, okay? It has a peak wavelength of 365 nanometer, okay? And what does it have? It has a low output mercury lamp fitted over a filter, which is called as Wood's filter, after the scientist. Sorry. So Wood's filter is composed of nickel oxide plus 9% barium silicate, okay? Please remember, Wood's lamp is composed of nickel oxide and 9% barium silicate, right? What is the fluorescence in different diseases that you get? Please take a screenshot of this also. Vitiligo, you get a very bright white fluorescence, right? Erythrasma, you get a coral red fluorescence. What is the causative organism of erythrasma? Cornybacterium minutissimum, okay? Pityriasis versicolor, caused by Malassezia globosa, you get a yellow fluorescence. Microsporum and trichophyton. In tinea capitis, this is particularly used, right? If the causative organism is microsporum, you will get a blue-green fluorescence, and if it's trichophyton, you get a dull blue fluorescence. So remember the examination findings of wood lamps in different diseases. It's very important. You will get a question. You might get a question on this, right? Now, next question. Dermatophytes can affect hair, skin, nail, all of the above. See, remember, dermatophyte is a keratinophilic fungi. Okay, it's keratinophilic. I don't know what is happening. Sorry. It's a keratinophilic fungi. It has an affinity for keratin, so it will affect hair, skin, nails, all, right? So the answer is all of the above. Next question is microsporum affects skin, hair and nails, skin and hair in different combinations. So see, there are 3 genera of dermatophytes that you have to remember. One is trichophyton. Second is microsporum. And third is epidermophyton. Okay. So there are 3 genera of dermatophytes that you have to remember. Now trichophyton, see, all 3 of them are going to affect the skin. First you remember this. Skin will be affected by all 3. Now trichophyton has it affects hair plus nails, meaning it affects all 3, okay? Skin, hair and nails, all 3 will be involved in trichophyton infections. Microsporum will involve the hair, okay? And epidermophyton will involve the nails. You do not get a hair infection because of epidermophyton. So microsporum will affect skin and hair. How I remember is by the brand H&M, okay? So microsporum is going to affect the hair. Rest all, it's very easy to remember them. Trichophyton, all 3, right? And Remaining is epidermophyton. It's going to affect skin and nails. So patient presents with a foot swelling, sinus and discharge. Identify the condition. See, this is very classic. All these three findings are a very classic triad for mycetoma, right? So mycetoma is actually a subcutaneous fungal infection of the skin. It's also known as Madura foot. Right? It's also known as Madura foot, and you get a triad of a mass, right, of a foot swelling, and there is presence of sinuses. How are these sinuses formed? You get painless nodules which ulcerates to form sinuses, and these sinuses will discharge grains. Remember, grains we had talked about, so there will be discharge of grains. What are grains? Grains are colonies of these packed organisms, of the causative organisms. So if you get a condition, if you get a question or a picture where there is a swelling, huge swelling, indurated swelling with sinuses, and there's discharge of grains, it is mycetoma, right? So mycetoma can actually be caused by a fungi also, where it is called eumycetoma if it's caused by a fungi, and if it's caused by filamentous bacteria, it's called as actinomycetoma. So it can be caused by a filamentous bacteria or it can be caused by a fungi. Okay, then you have to remember what are the color of grains in these two, because that is going to help you distinguish. So if it's black, it's eumycetoma. Dark colored black grains are a feature of eumycetoma. Whereas if it's not black, it can be white, cream colored, right? So it's actinomycetoma. So two things that you have to remember. You have to remember the color of grains. Grains will be black in eumycetoma, right? What is the causative organism? Madurella mycetomatous. Okay. Whereas actinomycetoma is caused by Actinomadura madurai, Nocardia species or Streptomyces species, right? Nocardia, Streptomyces or Actinomadura madurai. Most common overall cause is Nocardia, okay? And most common cause of eumycetoma will be Madurella mycetomatous. If you do a gram stain, you will get gram positive filaments, right? And here you will get hyphae because it's caused by a fungi, okay? Sorry, it's caused by a fungus, so you'll get septate hyphae. What is the treatment? Regimen that you have to remember is Welsh regimen, okay? Welsh regimen, very important. Where do you give the Welsh regimen? You give it in actinomycetoma. So it has cotrimoxazole and it has amikacin, okay? And there's another regimen called as the modified Welsh regimen. What is that? If you add rifampicin to this, it becomes the modified Welsh. Rifampicin is also given then. So cotrimoxazole and amikacin are the drugs that are given in Welsh regimen, and along with rifampicin it becomes modified Welsh. It was modified. And for Madura foot caused by eumycetoma, you are going to give azole. So you give itraconazole actually, okay? And usually it happens after a traumatic inoculation, because both of these are found in soil. They are saprophytes in soil. So it happens after a traumatic inoculation, usually in a field labor or a farmer who is walking barefoot. So there occurs traumatic inoculation of the organism and it eventually leads to this clinical picture. Okay, so mycetoma, very important, caused by both filamentous bacteria and true fungi. And if it's caused by true fungi, there will be discharge of grains, which are colonies of these organisms, which are black in color. And if it's not black, it's cream colored white, you're looking at actinomycetoma. Why important? Because the treatment is different. You have to identify, right, whether it's caused by a bacteria or a fungi. Accordingly, you will treat them. Correct? Moving to next question. A man presents with a hyperkeratotic crusted plaque KOH examination reveals the following findings. So what is the condition? You have to identify the conditions. What you are getting is copper colored bodies, copper penny bodies, right? Also called as muriform cells or sclerotic cells or Medler's body. All are same: copper penny bodies, muriform body, sclerotic body, Medler's body. This is a feature of chromoblastomycosis, right? Very important figure also, very frequently asked also. A man presenting with a hyperkeratotic crusted plaque on his extremity, the most common site is leg, and you do a mount and you find these copper colored penny shaped bodies. So it's a case of chromoblastomycosis. Okay, why chromoblastomycosis? Because it's caused by pigmented fungi. These fungi produce pigment, which is why it's called chromoblastomycosis. Chrome is pigment, right? What is the cause? It's caused by Fonsesia species, Fonsesia pedrosi, Fonsesia compactum, and Pheolophora species. Not very important, but still you can remember. You get a verrucous plaque, and this plaque has black dots, okay, which is giving it a cayenne pepper appearance. So this plaque is going to have black dots, and that leads to a cayenne pepper appearance. And extremities are the most common site because there is a post-traumatic inoculation. You do a KOH mount, you get these bodies, and you give oral itraconazole for treatment, right? So let's now move to questions on bacterial infections. A 3-year-old boy presented with multiple coalescing lesions on his face. What is your diagnosis? See, you are getting crusted lesions. See the picture, you're getting crusted lesions. It's honey colored, right? Honey colored crusted lesions in the perinasal periorbital area. Very classic, and the population here is a child, so very classic of impetigo. Remember, impetigo is of two types. You have bullous impetigo and you have non-bullous impetigo. Because non-bullous impetigo is very contagious also, it is also called as impetigo contagiosa. Okay, what is the characteristic feature? You get honey colored crusts. You get honey colored crusts here in the perioral or the perinasal area. Right? It is caused by staph. So impetigo can be bullous and non-bullous. Non-bullous is also called as impetigo contagiosa, caused by staph and also strep. You get yellow honey colored crusting, very commonly in the perioral perinasal area. What is the complication? Very important complication is post streptococcal glomerulonephritis. Okay, post streptococcal glomerulonephritis. It usually happens within 2 weeks of streptococcal impetigo. So post streptococcal glomerulonephritis is a complication of non-bullous impetigo, right? Bullous impetigo is caused by staph aureus. The exfoliative toxin ET toxin will cleave desmoglein 1. So ET toxin cleaves desmoglein 1. Now what happens is, when the desmoglein 1 is cleaved, there is presence of round cells and the space is occupied by fluid, right? So you get flaccid bulla because it's subcorneal. Flaccid bulla. Desmoglein 1 is present in the upper layers of the epidermis and it's not compensated by desmoglein 3. If you have read immunobullous properly, you will know what I'm talking about. So you get flaccid bulla in the subcorneal layer and there is cleavage of desmoglein 1. And eventually these bulla rupture easily because they are very flaccid and they form thin crust. And what is the most common site? It is trunk. So bullous impetigo will involve the trunk, you will get flaccid bulla that ruptures easily and forms crusting, right? And leaves crusting. So how do you treat? You have to give antibiotics. You can give topicals like mupirocin. You can give fusidic acid, right? And if it's severe, you will give an oral antibiotic, preferably cephalexin, cephalosporins. Okay. Now, which organism is responsible for causing erysipelas? See, you are getting a fiery red rash in the picture, which is what erysipelas is. It's a fiery red rash. Well demarcated. See, well demarcated rash. Right? Fiery red rash, which is well demarcated, it is caused by streptococcus, right? It is caused by streptococcus. So erysipelas will involve the rash, involves the dermis and lymphatics, but cellulitis goes deeper into the skin. So you have to differentiate the two. Erysipelas will have well demarcated margins, cellulitis will have indistinct margins. It will not be very clear. And what is the causative organisms? Erysipelas is caused by strep, whereas cellulitis can be caused by both staph and strep. So these are important points that you have to remember. Okay. A male patient with high grade fever and headache, he had protein levels of 220 milligram per deciliter and glucose levels of 35 milligram per milliliter in the CSF. What is the probable cause? See, all the features that he's having, fever, headache, and the CSF findings are suggestive towards of meningitis, right? And in meningitis, you get purpuric lesions or hemorrhagic lesions on extremities. So the patient is actually suffering from meningococcemia. And you get all these purpuric lesions, and the causative organism is Neisseria meningitis. Okay, so just remember hemorrhagic infarcts, purpuric lesions on the extremities with fever, headache, and classic CSF findings. You're looking at a case of meningococcemia. An infant presents with the lesions shown in image after pharyngeal infection. The shown condition is, see, you are getting a very moist erythematous rash. Yeah, the skin has peeled off, right? And you're getting lesions in the perioral area. You're getting fissuring in the perioral area, and it has happened after a pharyngeal infection. So there was dissemination of the organism from this primary focus of infection. You're looking at staphylococcal scalded skin syndrome. Okay. See, what happens is there is cleavage of desmoglein 1 here. Just like in non-bullous impetigo, here also desmoglein 1 is being cleaved, right? So desmoglein 1 is present here and it's getting cleaved. So the cells are assuming a round shape and there is presence of spaces. Earlier they were polygonal together, right? But now they have assumed the lowest body surface area because of cleavage of desmoglin. Now the space between the keratinocytes is filled with fluid, which is why you get a blister, right? And because it is present subcorneal, there is a very thin layer of skin. It's only the corneum that is covering the skin. These lesions are flaccid, they are not tense. If the entire epidermis would have covered the been the covering of the pathology, it would have been a tense lesion, as you get in subepidermal group of blistering disorders. But here there is a subcorneal pathology. Only a very thin layer of stratum corneum is covering the skin, so you get flaccid lesions. So you get flaccid vesicles and bulla. Okay. So here the Staph aureus toxin is disseminating from the blood vessels into the skin, and it is cleaving the desmoglein, which is why there is presence of spaces. These spaces are occupied by fluid, and because the covering is only of corneum, you get vesicles and bulla which are flaccid in nature, right? So what you get is flaccid bulla, and of course this is going to peel off, right? So there will be epidermal peeling, leaving raw red moist areas. right, which you get in this patient. See, there is so much epidermal peeling and there is scale, right? And ultimately it is going to heal with, I'm so sorry, it's going to heal with hyperpigmentation. What you also get is periorificial fissuring. Okay, this is very striking of this condition. So what is happening? The exfoliative toxin is cleaving the desmoglein, and that is leading to formation of vesicles and bulla, which are flaccid, right? The child will be febrile, irritable, and will present to you with these sheet-like areas of epidermal peeling and red moist skin. You also get periorificial crusting and fissuring, which is very striking, right? And the skin is very tender to touch. If you touch it, it's going to be very painful for the child, correct? The mucosa here is normal, of course, because desmoglein 1 is compensated by 3 in mucosa, right? We had remembered. So mucosa here is normal. And how will you treat it? You have to admit the patient in hospital, you have to give IV antibiotics, and you have to give supportive care, correct? The other name was pemphigus neonatorum and Ritter's disease. Remember, we had discussed named diseases. So Ritter's disease and pemphigus neonatorum were the old terminologies. Now we called it staphylococcal scalded skin syndrome. Coming to STIs, what is the causative organism of chancroid? So causative organism is chlamydia Haemophilus ducrei. Haemophilus ducrei, right? Treponema pallidum is the causative organism for syphilis. Chlamydia trachomatis, LGV, lymphogranuloma venereum. Herpes simplex virus 2 is going to cause herpes genitalis. So you have to remember the causative organism for all of these, and to complete the list you have Calimatobacterium granulomatous. So this causes donovenosis. Okay. Now this is a very high yield STI slide mentioning all the diseases, the causative organisms, what are the characteristic of ulcer and lymph node, the incubation period and the treatment. So I'll quickly just go through this slide with you guys. So herpes genitalis, how does it present? You will get lesions, okay, you will get vesicular lesions, which are grouped together and which are painful, and they will rupture easily to form polycyclic ulcers with polycyclic margins. Okay, see, you have ulcers with polycyclic margins. So painful grouped vesicular lesions which rupture to form ulcers with polycyclic margins, characteristic of herpes genitalis, caused by HSV2. Okay, and these ulcers are very shallow and tender. The incubation period is 2 to 7 days, and you treat it with acyclovir, correct? Now moving to syphilis. Syphilis is caused by Treponema pallidum. You get a very single indurated painless clean looking ulcer, and you get a discrete rubbery non-tender bilateral lymphadenopathy. We will come to the characteristics on how to approach a case of genital ulcer. I'll just draw that flow chart for you. And the incubation period is about 3 to 90 days. Drug of choice we have discussed is benzathine penicillin, 2.4 million units IM you have to give after proper skin testing. Chancroid, the causative organism we discussed was Haemophilus ducrei, and you get a very deep undermined purulent ulcer, right? And it will have a ragged border, and it is very painful, and you get painful unilateral lymphadenopathy, right? If you do a gram stain, see, this is the gram stain from ulcer, you get a school of fish appearance. See, school of fish swarming together. So school of fish appearance, right? And how do you treat it? You give azithromycin 1 gram single dose. You can also give ceftriaxone single dose of 250 milligram IM. Okay, lymphogranuloma venereum, it is caused by Chlamydia trachomatis. There are 3 serovars, L1, L2, L3, which is the most common L2 serovar, okay? You get a very transient ulcer. It often goes unnoticed by the patient. You know, the patient might not even know that he had an ulcer. It's a very transient, short-lived ulcer which is painless, and you get painful lymph node, and you get the groove sign which we had looked at earlier, right? The incubation period you have to memorize is up to 30 days, 3 to 12 days, and the drug of choice is doxycycline. Right? So this is the groove sign of LGV. Where you have the inguinal ligament separated by inguinal and femoral lymph node. Correct? And lastly, coming to donovenosis. So donovenosis is caused by Calymatobacterium granulomatis or Klebsiella granulomatis, and you get very friable beefy red lesions, and because of autoinoculation you get kissing lesions in the groin. See, so this you get kissing lesions in the groin because of autoinoculation of the organism, okay? And you get a beefy red ulcer. And if you do a crushed tissue smear, what do you get? You get closed safety pin appearance. Okay, because of bipolar condensation of chromatin. Right? So you get a closed safety pin appearance. How do you treat it? You give azithromycin. Correct? So this you have to remember all these points about all these STIs. Approaching a genital ulcer. So see, you have to look at two things. You have to look at ulcer and you have to look at lymph node. So see, if the ulcer is painful, you will think about two things, right? Herpes, and you will think about chancroid, because the rest three, the ulcers were painless. Then you look at lymph node. Now if the lymph node is unilateral and tender, it's a case of chancroid, okay? If bilateral, painful, tender, it's a case of herpes, right? And if the lymph node is normal, it's a case of donovenosis. You get a pseudobubo here. It is a false swelling. It's not a inguinal lymph node swelling. It's a swelling because of autoinoculation of the organism, right? So it's a pseudobubo. If the lymph nodes are painless, it's syphilis. Painless ulcer, painless lymph node. And if the lymph nodes are painful, it's a case of lymphogranuloma venereum, right? So painful ulcer, painful lymph node, you have two causes, herpes and chancroid. If bilaterally are involved, and of course the presentation is also different. Herpes will have vesicles, small vesicles which rupture to form, shallow ulcers, and it will have lymphadenopathy which is bilateral and painful. But if you have a very deep undermined ulcer with ragged borders and painful in nature, and a unilateral painful lymph node, bubo, it is chancroid. But ulcer, if you have painless, you have to look at the lymph node. If it's normal, it's donovenosis. If it's painless, lymphadenopathy, discrete, rubbery in nature, it's syphilis. And if it's a painful lymph node with a transient, unnoticed, painless ulcer, it's lymphogranuloma venereum. Correct? Lastly, we'll just look quickly at vaginal discharge. Curdy white vaginal discharge is seen in candidiasis. See, you have to remember vaginal discharge also very important, right? So if you get a curdy white discharge, it's candidiasis. The causative organism is Candida albicans. Okay. You don't get a vaginal discharge in syphilis. Trichomonasis, it's Trichomonas vaginalis. You have a greenish frothy discharge here, okay? You have a greenish frothy discharge, right? And if you have bacterial vaginosis, it is because of a imbalance in the commensal flora. So if you have an overgrowth of Gardnerella, Mobiluncus, Prevotella and bacteroids, and there is a decrease in lactobacilli, it leads to bacterial vaginosis. There is no inflammation here, hence it is called vaginosis and not vaginitis, right? So you have a very grey off-white colored thin discharge which homogeneously coats the vaginal walls, right? So that is characteristic of bacterial vaginosis. The drug of choice you have to remember, in candidiasis you will give azole, fluconazole. In trichomoniasis you will give metronidazole or secnidazole, and in bacterial vaginosis again you will give metronidazole. Okay. Now let's quickly look at this criteria. This criteria is used for diagnosing bacterial vaginosis. Right? 3 out of 4 if present strongly suggests bacterial vaginosis. What is this test? This is the whiff test. This is the number 1 criteria. So you take patient's secretions, you put a drop of KOH, and then you have to whiff it. So it gives a fishy amine odor, right? Fish-like odor. Right? What is this? You have to measure the pH. If pH is more than 4.5, then it's another criteria. Then you get what we talked about was clue cells. What are clue cells? These are vaginal epithelial cells coated with Gardnerella vaginalis. Very important. Clue cells are vaginal cells, epithelial cells coated with vaginalis, Gardnerella vaginalis at the borders, okay? And last is a homogeneous off-white greyish discharge coating the vaginal walls. Right? So these are the 4 parameters in Amsel's criteria. Fish-like amine odor, pH more than 4.5, and you have presence of clue cells and homogeneous white discharge on examination. So remember this Amsel's criteria. So we'll end our discussion today for now. I'll take another class in which we'll discuss other topics that are relevant for Fmge examination. I hope you enjoyed revising dermatology, and keep tuned to all our further revision series, all the subjects that are coming up. I'm sure you'll benefit from it a lot. Thank you so much for watching. Keep reading, keep revising.